Hello and welcome to today's presentation on chronic pain and the injured worker. Today, I'm hoping to shed new light on an old problem which has been plaguing the workplace and people who work there for years and years. My name's Mark Hardy and I'm the Medical Director of CA Clinics Australia, and welcome to this presentation. I currently work in two major sectors of my current professional life. The first being as a visiting medical officer at Northern Beaches Hospital in the field of addiction medicine. And the second working as medical director of CA Clinics Australia. This is a remote access clinical environment in which we provide medicinal cannabis advice and prescriptions for people who have a variety of conditions which meet TGA guidelines, such as chronic pain, anxiety, insomnia, cancer-related nausea and vomiting, epilepsy, and other related conditions, including movement disorders. Before you on the screen, I've also included some of my other previous experience, as well as the other areas that need to be declared as interests. Today's learning objectives include looking at the harms of chronic pain and addiction. We're going to look at how to take a chronic pain and addiction history. Thereafter, I want to point out some of the more important salient features of a physical examination to you. Thereafter, we'll talk about yellow and red flags, particularly with respect to the use of opioids in chronic pain. I want to talk about the WHO hierarchy of chronic pain and challenge some of the areas where I see validity and where I see that it needs to be updated. I want to talk about evolving new pharmacological managements for chronic pain. And I want to look at how we're going to manage informed consent for those sorts of treatments. Finally, I'd like to touch on some of the challenges that face the medicinal cannabis industry in terms of treatment for the injured worker. Moving on to the next slide, there's a really important graphic here that I wanted to show you. Presentations during the first decade of the 2000s for people who presented to hospital with poisoning from opioids, whether that be form of misuse or whether that be overdose and subsequently unfortunate death. In the first part of that slide, you'll see that the majority of people who presented to hospital at the start of the decade were presenting with illicit opioid use, such as heroin. But by the end of the decade, most people who presented with opioid overdoses, in fact, presented because of pharmaceutical overdoses. And this is of great concern to us as addiction medicine specialists, because what it indicated was a almost seismic shift in the way people utilised opioids during the course of the first decade of this century. And it has persisted beyond that into the second decade and beyond. In fact, only recently have legislative changes been put in place to make it more difficult for patients to access funded treatment with opioids as a protective public health measure to hopefully reduce the risk of overdose in the future. When we look at the significance of opioid-related deaths in the community, we turn to statistics from the Australian Institute of Health and Welfare. The most recent publication scanned over the deaths that occurred between 2018 and 2019. And they found that of 1,740 drug-induced deaths, opioids were present in over 64% of them, still making it the largest burden of disease and death of all drug-related deaths in the community. Interestingly, pharmaceutical opioids outstripped illicit opioids, and synthetic opioids such as tramadol and fentanyl were tending towards an increase. These drugs are more dangerous in the presence of sedative medications, including tranquilizers such as benzodiazepines and alcohol. In terms of burden of disease, tobacco and alcohol and illicit drug use collectively account for over 16% of all diseases in Australia. Illicit drug use accounts for 2.7% of that, and opioids are still the largest problematic substance of concern. In taking a history in realistic GP times, we have to bear in mind that GPs tend to have somewhere between 15 and 20 minutes for most consultations. Where GPs see patients for the first time, or a special consultation is booked for a particularly complex problem, GPs may well reserve 45 minutes to an hour for a patient. But a realistic GP timeline would be somewhere between 20 and 30 minutes to unpack a detailed, problematic pain history from an injured worker. And in that, we would need to discuss things such as the history of the presenting complaint and how it came to be that that problem manifests itself. And that may take up to 5 minutes to fully unpack with a patient. We'll need to understand the past medical history and any medications and treatments that the patients are on. We'd like, in particular, when we're thinking about using substances with a potential for addiction, to take a drug and alcohol history from patients. We'll need to go through each substance that patients may have been exposed to, one at a time, ask them questions around the age of first use, if their use was ever problematic, how they desisted from use, if they have, whether or not they required detoxification or experienced any significant withdrawal symptoms, and how long since they last used. These important points for each particular substance, going through opioids, benzodiazepines, alcohol, stimulants, cocaine, hallucinogens, tobacco, and even process addictions such as gambling or gaming or shopping or the internet, gives us an overall picture of sort of social state that the patient finds themselves in when they're coming to see you with a chronic pain problem. It's worthwhile to stop for a moment and also checklist some of the potential psychiatric problems that a patient's experienced. This doesn't need to be an exhaustive 30-minute exploration of the patient's psyche. More or less, it needs to encompass the concepts of psychiatric presentations the patient may have had in the past. These might include presentations for hospital because of severe depression or crisis, or self-harm episodes, or whether there's ever been any major psychiatric diagnoses made of the patient and by whom, whether they've had diagnoses such as depression, anxiety, bipolar, or even a psychosis in the past, whether these have been professional diagnoses or armchair diagnoses from friends or relatives. It's important to delineate that these are actually professionally made. Obviously, thereafter, we'd like to take a little bit more history around allergies because we're thinking about drug treatment for patients with chronic pain. And we need to understand how the patient lives. Are they going to be safe with medication? Are they able to store medication safely? Do they have support for their treatment? So an adequate social history needs to be taken. Things like education, housing, developmental history and trauma is really important for us at this stage. I like to include something on functional capacity because this is really important, and rather than get bogged down on each and everything, you can get from the slide a sense of the sorts of things that are required when we're looking at a functional capacity type of assessment. When it comes to workers' compensation cases, I think the functional capacity is often misunderstood or left out of a consultation, but it's really important because it's actually a good way to benchmark and KPI improvements in patients. So it's good to go back and see what a patient can and can't do, and not necessarily just going off previous workers' comp or workers' capacity assessments, but doing your own. So for things that have to do with work, it might be things like lifting, pushing, pulling, walking, standing and driving. It could include other things depending on the particular context of the work, like keyboard work, which is a particular manipulative skill that requires hands. I like to talk about recreational things because when people lose things and we want to try and see if we can get them back, it's important to understand how they were before they got hurt. What things have they lost and how that might affect them psychologically. We like to think of people working together in a household so that domestic duties are shared. So it's always important to ask people what they were doing beforehand and what things they can't do now. It's also important to know what they can do and how they've compensated for their injury. So it's also worthwhile asking them about the things they can do and how they go about doing them. The fourth important domain of functional capacity is activities of daily living. And these are very basic but important activities that need to be covered. Things like washing, showering, grooming, eating and drinking. Can a patient do that on their own or do they require help? I like to gain some sort of insight into how they live their lives on a day-to-day basis. and this provides me with better insight into how to treat them in the future. Often, I find that doctors are a little afraid to ask about relationships and intimacy, but this is actually a really important part of an injured worker's life. Some of our workers have their work lives cut short at an early age, but regardless of when they stop work, that's not the only thing that stops. Sometimes home life can deteriorate significantly with patients, and things like relationships, communication, time with your partner, and intimacy, including sexual intimacy, is important to discuss, and we shouldn't feel ashamed or shy about discussing it with our patients. In fact, it's interesting when you start to discuss these things with patients, how much they open up to you about what's going on with their relationships. And they feel much more likely to trust you if you're prepared to broach some of these difficult subjects with them earlier on in the process of assessing a patient. When it comes to examination of the patient, we have to examine both the whole patient and the painful part. And we obviously observe the patient for various manifestations of injury, including symmetry, their gait, the length and girth of a particular limb that we're measuring, their range of motion, whether or not they can straight leg raise for spinal conditions and nerve root impingement are important. We need to look at their motor function, their sensation. We also need to do a general examination of the client. There's no point in suggesting someone go on an exercise program if they've got severe heart or lung conditions that would prevent it. So it's timely to take a step back and look at the whole patient and make sure that everything else about them fits with the condition that they've got and that the treatment does not mismatch with the physical conditioning of the patient. I always do a mental state examination, and in fact, when I'm doing an interview with a patient, the mental state examination is something that I'm doing while I'm talking to them and while I'm listening to them. You get a sense of their presentation, you can get a sense of their speech, their ability to cooperate, their mood, their affect, their thought processes. It's very, very obvious to a doctor earlier on in an assessment whether a patient is in the room mentally as well as physically. It's important to do a risk assessment on patients to determine whether or not the injury or its treatment is causing a significant enough depressive mood to make them feel like they want to self-harm. Because obviously this raises one's concern about the potential for a psychiatric emergency. In the past, opioids had been promoted significantly for the use of chronic pain, when in fact, for the most part, opioids evidence is largely confined to acute pain episodes and peri-anaesthetic indications. Be that as it may, we now confront ourselves with a situation where we have a large cohort of people on moderate to high doses of opioids on a daily basis for the treatment of chronic pain conditions. It's important to familiarise yourself with potential yellow and red flags for opioid use. Some of the time, patients will escalate doses on their own because they're in pain or their pain's poorly controlled. And these are things that we have to accept about the treatment that we give people, that sometimes the treatment isn't up to scratch and the patients take treatment into their own hand. And whilst this is an area of concern, it's not an immediate red flag for us to cease treatment with patients. Again, the same thing would go for poor diurnal pain control, early prescription requests once or twice, or even an increasing opioid requirement despite poor pain control. However, if the situation persisted month after month and included some other more concerning behaviours such as prescription loss or doctor and pharmacy shopping or buying or selling medication outside of a therapeutic context, or using a medication in an unintended way, such as injecting or snorting an oral medication. These sorts of things, along with unsanctioned dose increase and ongoing poor control, would indicate that we are dealing with a red flag situation. The opioids are no longer therapeutically beneficial and need to be reconsidered. We need to remind ourselves when we're doing pain treatment what the aims of treatment actually are. And according to the Australasian Pain Society, a 30% pain improvement is the standard. Anything better than that is an advantage, but isn't an utter requirement. We need to think about improved functional capacity. We want to reduce adverse effects such as side effects of treatment. We know that opioids are not without side effects on some occasions, and patients desist at times from treatment with opioids due to side effects. We need to control those aberrant sort of yellow and red flag behaviours if we can, and above all, one of the things that we must do is reduce the risk of overdose. Which brings me to a point to consider about the way we perceive treatment in pain, and that's the WHO step ladder. It was originally designed for cancer pain, but was reiterated and remodelled for non-cancer pain. And it contains a number of interventions in a stepwise fashion, beginning with very simple analgesics and topical treatments, all the way to potent opioids and quite significant pain interventional techniques. Interestingly, opioids still feature quite significantly in this particular step ladder. And the question has to be asked, what about some of the novel and newer treatments, such as medicinal cannabis or transcranial magnetic stimulation, or even deep brain stimulation for that matter? These treatments, of course, are still under evaluation, thus the WHO have not included them in the step ladder. But as countries collectively start to de-prescribe opioids, it's something of a surprise to see them still feature so heavily in such an established and trusted algorithm as this. I want to talk a little bit about the evolving management of chronic pain in the medicinal cannabis space. There are two main products available in the cannabis plant for the treatment of chronic pain. The first is cannabidiol, or CBD. And cannabidiol is non-addictive, it's non-psychoactive, it doesn't show up in roadside tests in purified form, and recent studies have demonstrated that it doesn't impair machine work or driving. Now, occasionally people do experience drowsiness on starting this treatment, and it can be used as an aid to sleep. So if that does happen, then care should be taken when operating heavy machinery or driving, irrespective of whether or not it shows up in a test. We find that it is very good for inflammation and pain in chronic situations. And doses of between 25 and 100 milligrams twice a day seem to be effective for about 2/3 of patients who use it for this specific indication. It can help with sleep, and it also seems to help with pain coping, quite apart from the visual analog score of pain. The second product is Delta-9 tetrahydrocannabinol, or THC. Now, this is the psychoactive component of the cannabis plant, that it is possible to become intoxicated or stoned on THC. One should be mindful that THC doses used in a medicinal cannabis context are about 1/20th or less that which would be smoked or inhaled in an illicit sense. So we are essentially microdosing with THC to produce the beneficial effects without overly producing the intoxicating side effects. It needs to be borne in mind that it is illegal to drive with THC detectable in your system in every jurisdiction currently in Australia. So care should be taken with this product, and time needs to be set aside after using THC for it to wash out of your system, which can vary from person to person, and advice about that can be given to you by individual clinicians as to how long it would take for THC to leave the system. But it, together with CBD, can be a very effective pain reliever and anti-inflammatory. It seems to work in a slightly different way from CBD. It has a much more direct effect on cannabinoid receptors, which are receptors in our central nervous system, which modulate a variety of functions, including our experience of pain. We need to talk a little bit about informed consent because this is important. When we look at informed consent, it comes down to things like processes, costs of treatment, side effects, and pitfalls of treatment. So I like to run through these with each patient whenever I'm starting them on a treatment. We talk about how long it takes. It can take 7 to 10 days for the Therapeutic Goods Administration to approve the administration of cannabis in a particular patient upon application, even with fast tracking that we use every day via a secure computer link directly to their portal. The production of a script and delivery to a pharmacy can add a little bit of time, but these times generally only with the first script and with the initial application, and over time these things tend to settle down. Usually we see people monthly for the first 3 months, and then thereafter, if things are going well, we can taper off the appointments to about every 3 months, in much the same way as you would if you were seeing a specialist for referral for any other specialised condition. The costs of treatment need to be borne in mind, and they generally run at between $200 and $400 a month for fairly simple treatment. More complicated regimes can cost more. The second main domain of informed consent revolves around the cost of treatment. Clinics vary in their pricing from clinic to clinic. Insurers typically pay for medical consultations, but don't always pay for medication in the medicinal cannabis sense. And an independent consultation with an independent medical officer may be required for them to even consider it. That would leave the patient having to pay on the range of $200 to $400 a month for treatment, even if the treatment is fairly simple and uncomplicated medicinal cannabis treatment. For very complicated regimes, the treatments may cost more. We need to be mindful of the side effects of treatment, as listed in this slide, and they can be broken down into CBD and THC types of side effects. Whilst people are concerned about the risks of psychosis with THC, this is in fact a very rare complication. However, it is not completely nullified by the use of THC, even in low doses. When I say rare, I'm talking about 2 or 3 per 100,000 people, so it is very, very rare. Obviously, it's still illegal to drive on THC, and that's a significant pitfall of treatment. And it will show up in a urine drug screen. So if you're working in an area where you are screened, you'll need to declare this as a medication that you're taking. So it's important for people to strike a balance between the benefits and pitfalls of treatment. Just a brief word before we finish on the challenges for the medicinal cannabis treatment industry. First of all, obviously, there's individual dose control, which is an important challenge that we must follow. We need to try and get people engaged in treatment and get them to reduce their pain. And this helps to keep people in treatment and helps to maximise their early functional recovery. It may, in fact, help get them to things like physiotherapy and get them back into doing things that they weren't able to do before, increasing their confidence. We need more research evidence. There have been large-scale randomised controlled trials done overseas on various cannabinoids and various regimes for chronic pain. These haven't gained much traction in Australia in terms of getting ratification with other bodies in Australia. So the more people on board for doing research, whether it be the pain specialist group, whether it be rehabilitation specialists, neurologists, addiction specialists and GPs, I would think the more the merrier at this stage rather than less. We need to think about how we're going to do studies, because most of the studies that have been done in Australia are currently observational. It's very expensive to run new randomised controlled trials on cannabinoids, given that so many have been done in the past. But if it takes that to convince people that this is either helpful or otherwise, then we need to get ahead and do them. In terms of funding issues, of course, the position statements of both the Australian Pain Society and the Royal Australasian College of GPs currently don't favour the use of cannabinoids in open treatment because of a lack of sufficient evidence. How can we fix that? Well, we need more evidence, and we need them to help in gathering that evidence for us. Can we work together for a common good, which is something that I'd like to see us do more of? We have independent specialists or individual specialists in various different craft groups who are supportive of treatment. Can we combine together to produce better results for our patients? And of course, the other thing that's a big challenge for us is there's still no recourse for treatment in the PPS, in spite of the fact that the TGA has approved S3 products for pharmacy-only dispensing. So these are the challenges that face us for the future. I'd like to thank you for the time today to talk and open up for questions.